My name is Sam Young. I am a volunteer with the Portland People's Outreach Project, and this is my co-presenter.
Hey, my name's Elo. I use they, them, and I am going to be presenting with Sam.
I apologize. I use he, him, and his for my pronouns. We both volunteer for the Portland People's Outreach Project, but we have other hats in our day jobs. It's an outside work thing. Yeah, it's an interesting dynamic sometimes, especially because my employer is the health department. But we want to make it explicit that today our hats are the Portland People's Outreach Project. Background, our presentation is titled Radical Syringe Access, Harm Reduction Without Barriers, which is kind of a vague descriptor. Hopefully, as we present, you'll get a good idea of what we mean. And we're kind of centering the presentation around our experiences as volunteers in our organization, but we definitely think that there's a lot of overlap with and similar experiences that we've observed on other harm reduction organizations and syringe service programs, but we're kind of centered around our experience. So the Portland People's Outreach Project, PPOP, is a all-volunteer harm reduction program in Portland, Oregon. We are umbrellaed under the People's Harm Reduction Alliance, PRA, which its hub is in Seattle, but they operate throughout Washington and with us in Oregon. It's a nonprofit. They operate the U District Needle Change in Seattle. That was their original site, which opened, I want to say, almost 30 years ago. And about 15 years ago, they incorporated as PRA. And when they were founded, it was kind of in their original, I don't know if bylaws is accurate, but it was mandated the organization be peer run, which we'll get into a little later, but that applies to our site as well. And it's kind of an interesting relationship when we're in different states. But we share kind of some common unifying principles and values and practices. So our services are on 3 different days, and we operate primarily by means of outreach. So on Friday evenings, we do a bicycle outreach. We load up supplies in a tub and attach them to trailers to bikes and go out to about 5 or 6 locations. We go out on foot. We kind of drive to a few different locations, set up shop, and then move along. And then we have one stationary site, which is outdoors on a bike trail now. But previously we had a building, which was a really awesome drop-in center. And that day the day where we're stationary, we operate in an area of town where there's no other harm reduction services. And that is often kind of the impetus for how we chose where to go and when is where the need was and where nobody else was. And our kind of guiding philosophy and in theory and practice is our services are dedicated to loving people who use drugs. That can mean a lot of different things, but that is the kind of framework.
Yeah. And I think one question around that, and one that I've heard Sam ask with some regularity, a really central part of our conversation is what we're doing an expression of love in our community. And so I feel like that is a really important guiding principle for everything that we do.
So folks will often hear in public health and harm reduction, particularly the concept of meeting people where they're at. We really embrace that in a lot of different ways. So it means physically meeting people where they're at, going out to camps, going out to where people are. We got into this a little in the panel discussion, but we believe very strongly that our services and harm reduction services need to take the onus off of the participant and the end user, the onus for being able to be healthy and safe and have access to the things they need. It absolutely should never be come to us, we have it, come get it from us. People need to have services where they're comfortable and safe, and in recognition of the difficult lives they sometimes face trying to survive in the face of lack of safe drug supply and drug prohibition. So we try to go physically where people want, and we try to be guided. I think extending from loving drug users, we try to be guided by the people we serve. We listen to them. Being peer run, as you know, we'll get to, but you know, we listen to what they need, and we let them determine how the shape of our services. And so often that comes down to, hey, I need X or Y supply. I need this size syringe. As we'll kind of get to, we began offering meth pipes several years ago, directly in response to a need. Participants said, we need this, we want this. And it's really important to know and take as kind of an entree point that you can't hope to engage folks in all these other things that perhaps have a public health kind of goal in mind if you don't meet a material need first. And some folks may perceive that as bribing participants or may look at it in an otherwise problematic way. We don't. We think that people are struggling in a capitalist society. A lot of our participants are houseless. They have a lifetime of trauma that they bring to the table, and you can't really have a productive conversation if you're not giving them something that's going to enhance their immediate reality. Because we're centered on an organization, we kind of ask what's different about us and what's different about radical harm reduction. So there's some practical differences, and then there's some bigger philosophical differences. I think eliminating the distance between service provider and client. A number of us that had accessed services, syringe exchange service before, had gotten the kind of felt that there was a climate of, we're the cool harm reduction providers, you're the recipients, like you take what we give you, we're the experts, and that was kind of exactly how we did not want to run our services and operate when we began. So we intentionally promote participants volunteering. In fact, on the days we operate, Sunday, for example, where we do the foot outreach, we will tell folks who are interested that come to access supplies at one site, hey, come with us downtown to our next stop. You know, being peer run means a lot of different things. I think it's in Seattle, their site's kind of prerogative is that at least 51% of volunteers need to be active users, and they define active users as someone who does or could in the near future access supplies. We have at different points had different kind of measures of our capacity for being peer run, and our ability to like honestly and faithfully say that we're peer run. I think it's a continuum, and we're perpetually trying to improve. But we try to empower the folks when they're at services. And so, for example, pre-COVID, we were letting people grab their own stuff. We don't want people to feel constrained by lack of access. We want people to take what they need, and we want them to feel like we're not professionals providing a specialized service. We care about our community, and we're meeting a need. Which is not to say that we don't bring science and evidence and public health experience into it. And then, we kind of go where there's a need, and we do what the community tells us. And so we fortunately are able to do that because we're not confined by certain bureaucratic restrictions. Being an independent nonprofit has its pluses and minuses, but that's one of the pluses. So one of the important elements of doing radical harm reduction is moving beyond the confines of we serve injection drug users. Reducing disease transmission is our priority. So historically, that was the kind of impetus for harm reduction, is we need to reduce transmission of HIV and hepatitis C and other bloodborne pathogens. And so in order to be able to do that, you needed to offer syringes so people wouldn't be forced to share. We're really moving beyond that to the notion that we want to enhance the health and happiness of the people we serve. And just because something doesn't have a disease transmission kind of justification doesn't mean it's not valuable, and doesn't mean that it's not a beneficial service from a public health perspective. So about a year after we began operating, we started offering meth pipes, and then shortly thereafter, snorting supplies. This is a huge tool to be able to get more people in the door. And I think, getting back to radical harm reduction, we want to get everyone who uses drugs in the door for community, for support, for love, and for the tools they need in education. And you can't expect to serve smokers if you don't offer pipes. And then, there's all types of ancillary benefits. By offering pipes, you're getting people in the door that can now have access to naloxone where they may not otherwise, that they now have access to support with kind of triaging to resources and services and referrals, and just having creating a long-term framework for interaction. People use drugs throughout their day. Pretty much majority of places they go, they're treated like shit and made to feel like a criminal and like they are immoral because of what they put in their body. And so we wanted to erase the stigma associated with smoking, that like, oh well, that doesn't have anything to do with disease reduction, so it's not relevant to us as harm reductionists.
Yeah, I would just add here that I think it's important that we recognize that there are a lot of different expressions of harm reduction, and the historical roots of harm reduction came from people taking care of each other, from people who were using drugs and who were participating in sex work, looking out for each other. And that since then, we've seen many different manifestations of what harm reduction can involve. And I think it's important that through this approach, and by centering community in the work and engagement that we are participating in, we start to expand our definitions of health so that it extends beyond just the physical, which I think is a strength of the more public health oriented approach, is that it's really great at looking at some of those physical risks. And in addition to those physical risks, I think there's also these really deeply impactful social and psychological and spiritual risks that come along with drug use in our society, that's embedded in so many contextual factors. And so really trying to center relationship and community in a way that creates a space where people are seen and heard and appreciated. We start to see a kind of a holistic well-being that includes some of those dimensions of what it means to be well, where we're looking out for each other.
Yeah, I think kind of one element of doing radical harm reduction is kind of embracing the idea that your job is not to reduce the consequences that come, the inherent consequences that come from using drugs. Your job is to enhance people who use drugs, their ability to be healthy and happy and flourish. And I think that part of that, necessitates an understanding that the large majority of what we can culturally conceive as the harms of drugs, or that are inherent to using drugs, are in fact very, very complicated and connected to prohibition and the lack of a safe supply. And so being a radical harm reductionist means, you have to question these sacred cows, which we're going to get to. And I think when you have that perspective, you start to have really creative ways of enhancing health and happiness and pleasure, because, people, we can't escape that pleasure, and there's a big continuum of pleasure and self-medication and addressing, trauma and surviving and coping. But when you can support folks in achieving what they want when they use drugs and having control over their highs, I think one of the really good examples of this, when we began offering pipes, we increasingly were hearing from people, hey, now that I have more access to this, it's not necessarily, oh, I'm suddenly not going to inject at all anymore or completely switch over. It's that I can control how long I'm high for and the kind of symptoms and what I experience. And for some folks, they report it's really beneficial to be able to smoke rather than inject meth. So, the high doesn't last long. They don't have to be up for multiple days. Some of the kind of potential meth psychosis symptoms don't appear. And so it's a way of empowering people to take control of their drug experience. And so, yeah, the harm reduction sacred cows. So unfortunately, a lot of harm reduction institutions and services are relying on funders. And if they are public health or government services, they have, political imperatives that they have to attend to. And so we saw that when we began offering pipes, those other entities responded, well, there's no evidence for that, so we can't do it. And so number one, I think there's two kind of big kind of false notions that underlie a lot of the discourse around drugs in our society, and that harm reduction entities have to kind of confront constantly, which is one is that community-based needle sticks are a huge danger and something we need to spend time on kind of addressing, and that that by offering syringes, particularly if we're need-based, we're going to increase the likelihood of needles in the community, despite all types of mitigating practices, sharps community sharps containers, outreach-based needle collection, whatever. There's perpetually going to be this notion that if you operate syringe services, you're responsible for the increase in needles on the ground, and that's a public health danger. And you know what? It's not always feasible to say, but we feel it's important to say of that. The evidence shows that community-based needle stick is not a significant public health danger, and we shouldn't have to justify ourselves in terms of, hey, we're not causing an increase in needles in the community, and it's just it's unfortunate that so many syringe exchanges have to face that. And then the other one is that the notion that we enable or increase use, and so I think there's this notion sometimes that harm reduction and research and evidence are on two different sides or are siloed. And I don't believe that. I think that I feel like PPOP and the work we do is very grounded in evidence and science. Maybe the science isn't there yet. For example, in 1980, there wasn't science demonstrating the benefits of syringe access or syringe exchange, but that didn't mean that it wasn't valid. And so the notion that we in any harm reduction in any way enables or promotes drug use is another thing we have to face constantly, and it really needs to be addressed front and center. There's not one shred of evidence that exists to suggest that, and even with offering pipes, for example, there's limited evidence for the impact of pipes in reducing disease transmission. That wasn't why we offered it. It wasn't limited evidence. It was the kind of imperative of participant request. But the evidence that us offering meth pipes would increase drug use just didn't exist.
I would just add to what Sam is saying that because we are independent, it allows us some space to be adaptable and responsive to the things that people are asking for, and that to us is sufficient. So I think it comes back again to some of those social risks that are situated in the context of a broader sort of like approach and understanding of drug use in our society, and that by by responding to the things that people are asking for, we're able to lift up and celebrate the humanity and the expertise that people have in their own lives, in a way that I think that evidence will come to,
right.
And that there are these like measurable impacts that with the appropriate research will likely have findings that support this, and that even in the absence of that, it's sufficient for us. It's worth celebrating that people know what they need and that we can respond to that. So we do have some flexibility, being independent, which is really helpful.
And doing radical harm reduction also means taking the responsibility of advocating in the public sphere, which we'll get to in a minute. It is our responsibility to push radical harm reduction and push the practices and interventions and approaches that maybe don't have that firm research foundation, but that and that are much more kind of taboo in the mainstream. Because when we push those and we try to normalize them, that's going to make mainstream harm reduction much more palatable to people that might otherwise be shocked or uncomfortable with the idea of, for instance, syringe exchange. So it's like the margins pull the center, and we're afforded the luxury and privilege of being able to promote these things without fear of losing funding or otherwise consequence. And so because we have that privilege, we feel it's our responsibility. So yeah, I think a bigger idea that is sometimes missed is the notion that harm reduction and recovery are at odds, or harm reduction and radical harm reduction and public health are odds. I think we believe in offering our participants what they want. Our kind of phrases, we want our participants to be the best damn drug users they can be. And if they don't want to be drug users, they don't want to use drugs, then we want them to be the best damn happiest human they can be who doesn't use drugs. And so our participants tell us they want MAT. They, in some cases, want detox. They want treatment. Our volunteers have, built long-term relationships, supported folks when they've expressed the idea of wanting to go to detox and choose a different path. And we do things like drive them to detox at 6 a.m. and then meet them when they get out. So, our kind of the NIMBY critics in Portland have sometimes trotted out the notion that we're just promoting use. And it's like, we don't brag about getting people into treatment, but that's one of our many services. I think, again, getting back to our mission is to promote health and well-being. We don't tell participants what that is for them. So for some of them, being, using less chaotically is health and well-being. Some of them, it's, they will never want to be sober because they are miserable when they are sober. And so we want to collaboratively understand, and build health and happiness. Our anecdotal experience, and I think bigger evidence, is that harm reduction is more effective than abstinence or other kind of approaches in reducing chaotic use and supporting folks in accessing recovery services. People are going to go where they feel safe and loved to ask for help if they want help. And so they're going to come to us. They're not going to go to the entities that have been judging them and kind of coercively demanding that they stop using their whole life.
I think really just centering what so many harm reductionists, I think, are really lifting up in that we want to support people in whatever is going to look like the best version of the life that is possible, and recognizing that is self-determined. So self-determination means that there is space for whatever kinds of supports might be helpful.
We know we're running low on time a little bit. Just to really kind of concisely summarize, there's a lot of benefits and a lot of challenges being peer run. We're also all volunteers, so that's itself an additional challenge. I think, we want to mention, we kind of have to manage the drift towards professionalization. You have to perpetually promote volunteering to participants. You have to perpetually promote drug user involvement in the organization, whether it's an advisory board or some type of voting process, whatever your structure is. As long as there's some horizontal, design and implementation of services, and as long as you're kind of taking it as your perpetual mission to listen to the people you serve and have them empowered in your services, things are that peer imperative is gonna succeed. Do you want to add anything to this?
Yeah, I think the very organic model that we have does have a lot of flexibility. For those of us whose lives might be a little bit more chaotic, it does create some more space for us to be adaptable and responsive, like we were talking about earlier, and that there is a recognizable trade-off. There's less structure to manage logistics.
We, as we've said repeatedly, we listen to what our
yeah. And part of that, part of those logistics, I think, are benefited from some of the partnerships that we have with other organizations in our community. And so there's this like very like robust and diverse dimensional kind of like approach that allows us to be as responsive as possible. And I think what it always comes back to is centering our community. For those of us who are using, that means guiding the decisions that are made, and then allowing those other branches of the partnerships and the spaces to support that being in the center.
And we take it as a task, and radical harm reductions need to take it as a task. You always need to be working to reach communities you're not reaching and involve communities you're not involving. And you can never be satisfied with where you're at. You have to reach out to marginalized communities that are not sufficiently represented or involved in, whether it's our organization or harm reduction in our area or whatever, at whatever context. It's a responsibility of a harm reduction program to ensure parity and equity and value in having all communities have a seat at the table and not to be tokenized. And then, our kind of just to finish, as we said before, we have a responsibility to do public advocacy. We, in lieu of a drug users union, which we're building in Portland, and maybe not to duplicate services, I think we have a responsibility to advocate in the public sphere and in the media for the importance of our services and the dignity and worth of people who use drugs, not as victims solely and not as people who are sick, but as our community members who we love and who we want to empower to experience pleasure, but also to experience health and well-being. And so one of the, pass off to Elona, one of the most important kind of strategies I was taught was, don't get caught in the details. Don't try to win a who's louder voice. Don't try to argue the evidence. Folks like George W. Bush and Trump, as sick as it sounds, are master propagandists. They know that making everything black or white makes it a lot more difficult for the opposition to appear to have credence in their arguments. So, if our message is we love people who use drugs and we think they deserve love and not stigma, and love and not kind of being marginalized and ostracized, and don't try to, justify what we do on the basis of, we reduce disease and X or Y. it's like, we love the people we serve. You know, they are dying and going, you know, having horrible infections and suffering in many ways. And, you know, all our community deserves love and support and health. And when you don't try to go to the lowest common denominator of trying to appeal to, oh, we don't enable use, and oh, you know, we you know, take in this many needles a year, so you're not going to get, you know, a community-based needle stick. You know, those lowest common denominators are not, that's not what radical harm reductions should be doing. And they're, I think, in the long term, sometimes necessary, but can be harmful to the ability to build more sophisticated and empowering messaging.
Yeah. Yeah, and just to close, in recognition of some of the broader context of things, you know, to me, I think that radical harm reduction is an inherently anti-racist practice. We are tasked with dismantling the oppression that's shaping the context of people's lives, and by engaging from that space with the public platforms that are creating policies that continue to shape the context of people's lives, you know, I think that we can bring love into the sphere of public policy making when we continue to bring back the people who are at the who are experiencing you know, this context, and making sure to elevate the priorities that folks are struggling with, and finding, you know, the ways of building that bridge. You know, I think that there's a lot more that we can do there. So that was a lot. I realize we're a little bit over time. Want to make space for questions. It's really, you know, big conversation, and we kind of flew through some stuff there. So what questions do y'all have?